Thanks for having me here, and apologies. I'll have to rush off at about 10:30 to a care home working group, a care home meeting with Department of Health. So apologies. This is a kind of a flying visit. But really, this is just to look at some of the work we've been doing, looking at how we can monitor outbreaks in enclosed societies. So we've sort of probably 6 months ago or so, if you'd asked me why we're doing modelling, and I still keep this view, it's to look at emergency response and do real-time modelling, but also enable us to do preparedness. Clearly now we're in a response setting, and we're trying to work out how to visualize data and provide the sort of situational awareness that policymakers need. Again, prior to COVID, I'd probably be heavily, I was working on projects to look at model chains and uncertainty quantification with partners in DSTL and other organizations we haven't been able to, it has been sort of part of the advice chain separately. I'm not going to go into details of that, and but yeah, colleagues in DSTL are sort of working on how to provide model combination and such like of model outputs provided to SPI-M. But we had the challenge here of working out what was going on in enclosed societies, and so a care home is fairly detached from society, from the community at large. It's only really connected through visitors and through the staff, and then through hospital connections. But we really don't know what the contact structures within a care home are. We can guess. We understand that these are very vulnerable populations. We understand that sort of say dementia, people suffering from dementia will have specific care needs, perhaps needing more physical contact than other residents. But we don't really even know how staff interact within the settings. I mean, they obviously go back and mix with their families, but do they have breaks together and interact? So we do understand where the 15,000 care homes are. They're linked to postcodes and addresses. So we have some information on where people are, and we know how big the care homes are. And so we can start to sort of look at some of these aspects, but actually, as I'll come back to this in the summary, we don't fully know how the connection between the care homes and the health hospitals are. We know people leave care homes and we know people leave hospital, but that the connection of where precisely individuals go is a bit uncertain. So there are many data gaps is the essence here. And how did we get into this, or how did we stumble into this problem? How did I stumble into this problem? Well, some years ago, we did a small piece of work for flu, looking at outbreaks in enclosed societies, and that turned up a range of different outbreak reports in the literature. And okay, there may be reporting bias there, because not every outbreak will be reported or documented, but we were able to show that those outbreaks that were documented had higher attack rates than the smaller the outbreak, the enclosed society, the higher the attack rate. And that's obviously logical, in the sense that there's sort of, if you only got 4 or 5 people in a society and there's an introduction, then your attack rate will be naturally higher. There'll be sort of stochastic variability in that, as opposed to when you've got 1,000. So it's not a very profound result, but it does provide something for policymakers to plan around. And the the thing that we were able to tease out through some sort of simple regression analysis, mixed effects modeling, was that there was a difference in your role. So children and military personnel had a different, when you merge all the different outbreaks together, had slightly higher attack rates than residents and prisoners and staff in the prisons. So there's a sort of potential difference in your role in the society around what the attack rate might be. I'm not looking to extrapolate too far from this flu situation to COVID, but it is a something to build from. And what other evidence do we have from earlier work in the pandemic? So specifically for COVID, well, there were a lot of natural experiments conducted on cruise ships by operators and national. Obviously, the famous one, or the well-documented one, is the Diamond Princess that was moored off of Japan, but there were a spate of other cruise ships that had outbreaks, and without some sort of intervention could have had very significant outbreaks. So yeah, we saw there the potential role of transmission in these settings. And Lorenzo, who spoke earlier in the week, did some work looking at cocooning. So if you have a sort of background rate of infection, looking at importations. And the role that the different care home sizes might have on that. So I'm not going to go into detail on that work, but yeah, we have sort of looked at some of these aspects around other settings than just care homes, and looking at some of the ways that we might cocoon them. So we have a number of our initial data set that we were provided with was simply the number of new outbreaks per day. So no information about how many cases there were no meaningful information about how many cases there were within a care home, within one of these outbreaks. It was simply, of those 15,000 odd care homes, how many were reporting an outbreak. And so we thought, well, let's fit an SIS model, or try some SIS models to these. So the care home is the sort of agent, if you like, and they become contaminated through cases coming in, and then they clear those cases and become susceptible again to further importation. The data kind of grew exponentially, so relatively simple forces of infection didn't fit the data well, and when when you allow for force of infection proportionate to the number of infected care homes, that didn't fit new outbreaks being reported well. It was too constraining, so we ended up fitting a time varying force of infection until some sort of saturation was achieved. From that, we were able to then calculate, thanks to this being an SIS model, what the sort of fraction of the eventual proportion of infected care homes at any given time might be, from information from the new outbreaks reported, and some estimate of the duration. Now we have we've written this up, so it's on medRxiv. So yeah, you're sort of welcome to have a look at the underlying sort of technical details of that at your leisure. But this is the this is one of the key outputs. So this, we can fit a GAM to the data, basically. The time varying SIS function is similar to fitting a generalized additive model. We can allow for weekend effects. That, as you can see, the number of new reported outbreaks dips at weekends because there's less people to report them, and then there's a bit of a upswing during the week. As I said, this was leveling off. This was looking like it was leveling off at about 170, 180 new reports a day. Upper limit perhaps of 190. If you allow for that, and the fact there's 15,000 care homes, and make some sort of assessment of a generation time of COVID of 5 days, and 4 or 5 generations of disease within the care homes, and a 14-day period after the last case before you report you're clear, then you're up to about 30 days, over 30 days for the time to recovery. Putting those numbers together in a very simplistic way, as we've outlined, gives you about 40% of care homes will be in outbreak status eventually. Now that is that's relatively broad brush, and it assumes that this is some natural steady state, which it may not be, and I'll come back to that in a moment. But let's just look at the understand a little bit more about the population at risk. For those of you that don't know the care home sector, this shows the age profile of people that are in CQC registered settings. So there are some younger people, but it is mostly elderly people, and due to the difference in mortality rates, mostly female, which means that when you look at some of the mortality data, where we see in a bias towards men, that it changes as you get older, and that's once you adjust for the population sizes, that sort of disappears, and it's actually fairly stable, the risk ratio between men and women, as in men are more exposed and become cases. But if we look at the number of care homes at present infected, and at present we're operating at about 35% or have had at least an outbreak, at least one case to date. There is quite a difference in between size, and so we are seeing large care homes, large nursing homes operating with about 80% having had at least one case. Large residential homes down at sort of 60%, but nursing homes are worse off in terms of number of reports than residential care homes, probably because there's there's more connectedness. That may be because there's more connectedness to the hospital system, but also it may just be a nature of the staffing levels and the vulnerabilities of the people within the settings, and that's still under investigation. Looking at the second generation, so the lab data, so the PCR positive and negative data that's coming out of this sector now. Clearly there is a testing program going on in care homes, and the leftmost panel here shows the number of positive swabs nationally over time. That just shows that there's been sort of a rapid increase, and then there's a sort of decrease in the more recent times. Probably there's a reporting lag there, so I wouldn't get too hung up on the more recent dips in numbers, but potentially is showing that there is a there's a slight decrease after a peak in mid-May, that's in mid-April. But we can tease out the difference between the positive and negative cases. And we see there the middle panel are the positive swabs for one specific care home, and the rightmost panel are the negative swabs. And so here we're seeing the change in testing capacity. So suddenly at the start of end of April, start of May, sort of day 90-ish here, we suddenly see that testing became available, and they managed to do a blanket screen in this care home. So there may be issues with access to testing earlier on, but you see that there are these gaps. And so on day 60, that they had a case, or just before day 60 they had a case, and then there wasn't another case until somewhere in the mid-70s. So longer than 10 days. If we're assuming the generation time is 5 days, then that is probably some sign that there's one of three explanations for that. One is that there's a missed cross-transmission event in the swabbing data, so they may not have had testing capacity in that period. Another is that there was a false negative, and that's not really, there's no real negative tests in that period, so it's probably not a false negative in this case. Or that this was one outbreak, and this is a separate outbreak caused by this case being another importation. So that we really need to understand for the dynamics of these diseases whether it's what's the contribution of those three things. And the missed link may not be that they didn't have access to PCR testing. It may also be that they had asymptomatic infections in staff or residents. So yeah, there's a number of also reasons for that. But looking at this SGSS data a little further, we can see, if you look at that gap, it's quite stable across care homes as you increase the number of swabs within the care home. The gap, there is normally at least a gap of 10 days on average in those care homes, suggesting that there is something kind of something noteworthy there in that. And then if you look at the length between the first and the last positive test, you obviously for smaller care homes that sort of increases out, but it tends to stabilize at something like 28 days. And we need to think about what that means epidemiologically. But if you're thinking about clearing the disease and what's a sense that you got that you're still up at sort of 2 months or so, sort of extreme outbreaks. So the duration could be quite substantive. If you think back to the estimates we made for that 40% prevalence, was based on about 30-day duration. So yeah, these could be with the care home for quite a while on the current evidence. And then there's the spatial question. So where are these care homes, and what is that saying? So this is looking at the number of positive swabs at postcode level in the UK. Apologies, it's not the nicest graphic, not the clearest graphic, but what it shows is there has been a largish number of positive swabs in and around sort of the Newcastle area, in and around the Liverpool, South Manchester area, and in and around London, with some other areas glowing red as well. So there's a spatial distribution to this, and if we move on to the total number of deaths, so this is using lab data at postcode level. We don't have that death data at postcode level yet. We're working on that. So we have upper tier local authorities reports of deaths reported to CQC, Here you see a slightly different pattern. So you're seeing areas such as Hampshire and Devon and Dorset. Well, Hampshire certainly glowing red, and then moving across into Surrey. And it's sort of these sort of leafy residential sort of commuter belt, although obviously these are people dying in care homes, so they're not really commuting. And up here in the northwest. Now that's total deaths. That doesn't account for how many care homes there are, or how many where. So actually, Hampshire has had a lot of deaths. It obviously has a major problem. But actually, there's a lot of people retire in Hampshire. A lot of people do retire to care homes in Hampshire. So when we adjust for that, if we look at the number of deaths per care home, that shows a slightly different picture. And so we see again this band more in keeping with the pattern that we saw of swab positivity of this band across Liverpool and South Manchester. Perhaps some sort of the urban centre in the northeast, and into this sort of Oxfordshire. Reading seems to have sort of become bad as well. So there's definitely a spatial component here, and a spatial distribution that we're sort of currently trying to make sense of and understand. And as we look at the monitoring indicators more generally, we have these all-cause deaths reported to CQC. Again, this is by date of notification rather than date of death, so there's a weekend effect. But there was a peak mid-August, mid-April, and there seems to be a downward trajectory, and so this is fitting that GAM smoother to that, and we can look at the instantaneous growth rate. So the derivative of the spline effectively, to give us some indication of whether, so if this was exponentially growing, this would be flat. And so we do seem to be in some sort of perhaps exponential decay regime or similar. So deaths are going down in care homes, which is a good sign. Coming back to the number of outbreaks reported, if you remember the earlier graph, I truncated the time series about here, where it looked like we were plateauing, but that's because we sort of advised action earlier in April, and so the changes have been made, and so the number of new outbreaks has diminished, and gone down. Has gone down. So that's a good impact there from the modelling assessment. So in summary, we have the trend prior to sort of awareness of the problem in the care home sector seemed to be leading to a substantive burden of disease in that sector. And that has been modified, affected now in a positive way. We have good data on monitoring trends for mortality and outbreaks, and we're hopeful of finer scale data at care home level, so we can actually match the swabbing to the mortality data to come up with some sort of internal verification of the data sets. There are two key issues that I can't stress enough. One is that we seem to be missing information about staff in terms of the swab positivity, and that will obviously be made, that if we're ever going to do modelling within care homes, not only do we need to know contact rates, we need to know whether the staff are being infected and are acting as vectors of disease. And then the other issue is trying to understand the connectivity between hospitals and community, hospitals and care homes, that should read, because obviously people get discharged from hospital to care homes often, and people get sick in care homes and need to go to hospital. So there's a connectivity there. And we'll be working on the testing strategy moving forwards and understanding this sort of role of staff absence and looking at other settings of other enclosed societies than care homes. And I think that brings me to, just to say, this is part of, I co-chair with Charlotte Watts, the care home working group for SAGE, so yeah, there's Alicia Rosello in London School is working on a more detailed model trying to understand these contact patterns. And that's me. Over.
Good morning, thank you. We heard a very interesting talk yesterday about phylogenetic stuff. And so the question is whether, I mean, simple cases of one thing, but if you're really interested in whether the case was introduced or whether someone caught it, an interesting thing to do would be to do some really some DNA stuff. So that's a suggestion back for you and Charlotte.
Yeah,
that way you know whether it was, well, we know, you know, whether it was someone catching it outside, bringing it in, or whether it was internally communicated. And that's not, that's very important from a policy point of view, actually, isn't it? Because, you know, well, yes, obviously, and also from not exactly pointing the finger, but to say what they should be particularly careful about and helping to explain what actually went on.
Yeah, no, thank you for that. I think I kind of deliberately didn't talk about the whole genome sequencing work that is part of this, and PHE have done a deep dive into 6 care homes in London over the Easter weekend and looked at some of the yeah, I mean you can show from that the staff have a role in the transmission cycle, and that's not blaming the staff. They're not a very well resourced sector, so it's really about how we can support the staff. And clearly, if you're on a 0 hours contract, then you may feel pressure to work when you might otherwise be better off.
Well, and also the issue which happened earlier on of staff who work in several places, which was, I mean, that's obvious, but yeah, no, it's not about blaming anybody. It's about understanding, and also, actually, of course, the staff are a danger to each other.
Yeah.
You know, the other thing which is more difficult to track for you is when, you know, nothing to do with the residents. It's to do with when the staff, you know, it's like they say the risk of going back to school is that teachers will spread it among themselves, and so it's the same thing that, you know, you can take enormous care with the patients, and then you have a cup of coffee with each other, etc. So, which is human, which is natural, you know. So yeah, exactly.
Yeah. No, thanks.
Yeah. Okay, any other questions?
I think I can see Hannah Clapham has a hand.
Hi, thank you. Yeah, hi, Hannah. That was a really nice presentation, thank you. I was just wondering if you could talk a little bit more about the conclusion that the measures that have been put in place are working. I was wondering how you're determining that, given the testing that's been changing, and how the models are feeding into that process.
Yeah, no, I was probably a bit over simplistic in that statement, in that what we're seeing, I mean, it's difficult to prove cause and effect here. So we are seeing a sort of downward trajectory that is due to some sort of intervention. There are testing is ramping up, but I think they are certainly what I didn't have time to go into. There's a whole world of detail to this, but the spatial pattern that I sort of touched on, you can see the Northwest had a substantive outbreak. So some of that peak is due purely to the number of cases in the Northwest. Some of the other regions are more stable in their reporting. And so speaking to the Director of Public Health in the Northwest, in Liverpool, they put in place local action plans. And so there is a heterogeneous response that is somewhat coordinated, but there are definitely local interventions around maybe encouraging staff not to live at home in hotels and things, thinking outside the box slightly to make the interventions more efficacious. So not a good answer to the question, but it's complex, which doesn't really help anyone, but yeah, it does. Yeah. Okay.
Any more questions? If there are not more questions, we should thank Ian very much and let him get away.
Thank you.
So thank you, Ian, for excellent presentation.